fact, I have many questions and comments, but I will start with you, Sarper. You mentioned the survey that you ran, and there are two main questions that I have. Since there are so many different subtypes of lymphomas, in fact, Harris mentioned cancers, and I will come to this later. So, did you receive the same type of responses from patients with a different diagnosis? Have you looked at that? In other words, if you have a patient with what we call aggressive lymphoma, diffuse large B-cell lymphoma, I will not be too specific to avoid confusion, but do you get the same type of feedback regardless of the underlying diagnosis?
The snapshot that I've given you here is a sort of general answer. If you can split it, sometimes you don't get the same result. This is you have different fears, different concerns, etc. But it's not the same, but it's very difficult. As you can imagine, there are more than 80. Sometimes you have to have maybe at least 50,000 to be able to really compare all the sometimes, but 4,000
Thanks very much, which brings me to you guys. So I was really, what you did is really laudable. I appreciated it a lot. However, are you confident? I will shout. Are you confident that what you are developing and that your approach, which is rather generic, so are you confident that this one approach fits all would be valid across cancer types? There are very different things. Speaking as a hematologist, oncologist, I would say that there are very different things that are relevant from a clinical and lifestyle standpoint if you have breast cancer as opposed to when you have acute leukemia.
Yeah, you're completely right. We saw that because even if you have just breast cancer and prostate cancer, and you need to discuss with clinicians what they need and what the patients need, you can see that they have quite different needs. Okay, so what we try to do is to acknowledge this diversity and identify several, let's say, apps that are more targeted to one case and more targeted to the other case. Certainly, you cannot create one platform that fits all. You can only make it as a placeholder where more apps will be targeting specific cancer types.
Am I allowed another question?
Yes, please.
So again, I would like to ask you, Sarper, what about differences in responses from different geographical areas? In other words, I presume that some type of responses will be more or less similar, but what about the cultural background and the local context? How much does it affect the type of responses that you receive?
Well, it is difficult to compare, but we feel because we do the filtering and the analysis, etc., and you can play with the data that you have. If we did this analysis maybe 20 or 30 years ago, we wouldn't really feel much difference. When it comes to the access issues, because everybody is now on internet and everybody knows what available therapies are, so and we are really pushing for the cross-border healthcare, which is not the case at this time. So, I mean, I have shown you two slides, one with Serbia and the other one with Germany, for example. In Germany, you have 108 available therapies approved and reimbursed, whereas in Serbia it's nearly half. And this also affects the patients as well. They feel a little bit depressed. They feel a little bit helpless in regions where they can't really get access to the drugs.
Sorry, but I beg to differ with your view, because you said everyone is on the net, and I would say that not everyone is on the net everywhere in the world. So we are having a rather skewed idea about what is happening. And Christina, would you like to comment, for instance, on what was happening in the UK in this colon cancer prevention program, which run in the London metropolitan area? I think this is quite reflective of the actual situation, the huge disparity that we can observe even within the same city, let alone the same country or the same continent.
Yes, actually it was the bowel cancer screening program run by the NHS. And what happened was that patients who completed the 60th year of age...
Individuals, not patients.
Yes, sorry, individuals. Yes, that's right.
Healthy individuals.
Yeah, healthy individuals were asked to complete a kit and send it back for results. Within the kit there were, of course, directions. There was explanation of the background to this effort and so on. But this was not explained by the doctor. It was all sent by mail, and the sample was sent back by mail as well. So what they found when they ran the results is that in the London metropolitan area there was great diversity, of course. So essentially the good areas, the higher socioeconomic class areas, all responded. There was a very high response rate, about 80%, whereas maybe in the eastern part of London, lower socioeconomic classes had about a 20 or 30% response. So this means we gather from this that there might be a health literacy issue, and there might even be, I don't know what you could characterize it, but it just might be panic that essentially you receive a letter and it says that you are now you're at risk of developing bowel cancer from the ages of 60 to 69, and there's no one there to explain it to you. So sometimes a person can be more than the internet, I think. I'm a psychologist, so this is my comment, I think.
So Dr. Diler, you had a question, I think.
Yeah, a question and maybe a concern for the I manage cancer. So, I mean, there's a huge issue in European countries to integrate the data already. So do you have a sort of succession planning for implementation? Because, I mean, for example, patient records in Germany cannot automatically be taken by a UK hospital and be analyzed when the patient is transferred. And the second thing is that my brother is a psychiatrist at University of Pittsburgh, and they're working on a program. I mean, I see that the patient has to fill in a form or a survey of the psychological issues. Most of the times it is very difficult because when people are depressed, they either are not engaged in filling the forms or they don't give you the right information so that the physician could really analyze the real status of the patient. So they are just with these gadgets and things to see at the hospital or at the houses where they live, their physical status, their heart rates, etc. They make a sort of algorithm so that they can see if the patient is have a lower mobility and lower grade of depression or not. So would that be integrated maybe later on, because otherwise you won't get the real picture of the patient? Thank you.
Okay. So to answer your first question, how we perceive designing those apps is that indeed the patient by himself has to enter a lot of information. What we saw is that when you say to someone that possibly if you enter those data are going to help you or are going to help others, what we saw so far, okay, because it is right what you said, what we saw is that they do it. Okay, if they think they will help them, for example, a parent will do everything for his child. Okay, he will feel whatever you tell him, he will do everything. So this is one fact. On the other hand, we have, although we rely on a patient entering by himself the data, we have a real nice data management layer where that can be connected to any hospital system. Of course, as you know better than me maybe, the problems are not technical problems. Usually to get the data from a hospital, you have other problems. So the technological solution is there. As soon as other problems will be resolved, we are ready to get the data from really anywhere. And then now for the sensor that you said, one of the apps that was demonstrated in the video has this capability now. So we have sensors like Fitbit, for example, things like that, and we automatically get, as long as the APIs allow that, we get those details. So we're able to identify, for example, a patient is active or is not active, where he has gone, by just using these Fitbit tools. We do it already. Thank you.
I would like to make a question to all of you. We have seen a certain disease. We have been presented with a technological solution. We got an idea about what were the end user needs and requirements and the problems they face in getting access to treatment and the medicines they need to have. And my question would be, could these problems or is there a roadmap that you may have in mind so that all these issues can be resolved by means of alternative, possibly PHR solutions? How easy it is for the CLL module to be incorporated in other PHR solutions, and how easy, that's a question for Harris here, to find a marketing tool and a way of selling these services, and how easy is to exploit the solutions that you develop.
Well, I mean, I could comment on that, is that I already told in my speech that only 3% of the people and the institutions are doing different things. So, I mean, this is the first time that I'm coming to an eHealth forum, because otherwise I mean, as a medical doctor, I'm either in the medical community or with the advocacy people, but I mean, I have never been in a technology environment. I mean, and everybody is doing the same thing, talking with the same environment, having the same agenda. So now I can see the disparities, and then with the disparities, if we can just sit down together and sort out a common agenda, I think we can start having a same strategy to solve the problem. I mean, in general, I can comment like this.